Good morning, all. Today, the topic for our discussion is oral lichen planus. Before coming into detail about oral lichen planus, we should know what is a white lesion of oral cavity. Any abnormal area of the oral mucosa that on clinical examination appears whiter than the surrounding tissue and is usually raised, roughened, or of a different texture from the adjacent normal tissue. Now, why do some lesions appear white in color than its surrounding counterpart? The few reasons are increased thickness of epidermal covering with increased production of keratin, hyperkeratosis, production of abnormal keratins, imbibition of fluid by the upper layers of mucosa, coagulation of surface tissue, for example, that we see in burns, formation of pseudomembrane composed of desquamative epithelial cells, fibrin, inflammatory cells, microorganisms, and food debris. Now, coming to the definition of oral lichen planus. Oral lichen planus is a chronic mucocutaneous disorder of the stratified squamous epithelium that affects the oral membrane, the genital mucous membrane, the skin, nails, and scalp. The etiology or the etiological factors. Although the exact etiology of the disease is still unknown, some factors are associated with it. So these are the few factors. First one is the genetic background. Second one is dental materials, then drugs, infectious agents, autoimmunity, bowel diseases, food allergies, stress, habits, trauma, diabetes and hypertension, malignant neoplasms, and some miscellaneous associations. The familial cases, considering the genetic background, the familial cases are very rare in oral lichen planus. The dental materials, various dental materials like silver amalgam, gold, cobalt, palladium, and even non-metallic such as epoxy resins and prolonged use of denture wears are found to have an etiological reason in the formation of oral lichen planus. Drugs. The drugs associated with the causation of oral lichen planus are NSAIDs, beta blockers, angiotensin converting enzyme inhibitors, antimalarials, contact allergens, especially that is seen in toothpaste. Next is the infectious agents. Helicobacter pylori, Epstein-Barr viruses, human papilloma virus, human herpes virus 6, hepatitis virus 6. Next is autoimmunity. Oral lichen planus is associated with certain autoimmune disorders such as primary biliary cirrhosis, ulcerative colitis, myasthenia gravis, etc. The bowel diseases, for example, ulcerative colitis and Crohn's disease. The Crohn's disease is usually seen concomitant with oral lichen planus. Anxiety and stress are also considered to be an etiology of oral lichen planus. Trauma, it can be a mechanism by which other etiological factors exert their effect. Diabetes and hypertension, along with oral lichen planus, forms a triad, and we usually call it as Greenspan syndrome. Malignant neoplasms, and there are some miscellaneous associations. The pathogenesis is believed to be a T-cell mediated autoimmune disease, where autocytotoxic CD8 T cells trigger the apoptosis of the basal cells of oral epithelium. Coming to the clinical features of oral lichen planus, as discussed in the definition of oral lichen planus, we knew that it is a cutaneous disorder also. The cutaneous lesion of lichen planus are characterized by 5 Ps. that is the purple in color, polygonal in shape, it is pruritic, and the appearance of papules and plaques. The primary symptom of cutaneous LP is pruritus or itching. Orally, the disease appears or assumes somewhat different clinical appearance than on the skin. Orally, the age is considered to be 5th decade and have a female predominance. The common site is buccal mucosa on either side. The oral picture appears in 6 types: reticular, atrophic, erosive, plaque, papular, and bullous. Coming to the first type of oral lichen planus, that's a reticular LP. As seen in the pic, you can see there are slightly elevated, raised, lace-like fine white radiated lines, and this is known as Wickham's striae. The site, it is usually seen in the buccal mucosa, that is bilateral, also the tongue, lips, gingiva, and the palate. Atrophic lichen planus, inflamed areas covered by thin red epithelium, usually associated with gingiva, we call it as desquamative gingivitis. And desquamative gingivitis is not only associated with lichen planus, but it is seen in other conditions like pemphigoid, linear IgA disease, and dermatitis herpetiformis. Erosive LP, it is a complication of atrophic lichen planus where the epithelium appears abraded or ulcerated. It is associated with certain drugs like NSAIDs, hydrochlorothiazide, penicillamine, and angiotensin converting enzyme inhibitors. Certain diseases like hepatitis C, then contact allergens like cinnamon and peppermint, the mercury seen in amalgam restorations, and the erosive LP shows a malignant transformation or malignant potential up to 2%. The plaque type of LP, where there will be plaque white lesions, and it usually resembles leukoplakic lesions, and the site is buccal mucosa, tongue, and gingiva. The papular lichen planus, here the primary lesion is papules, and usually we know that the primary oral lesion of a lichen planus is papule. Later, these papules join together to form white lines, which we usually call as reticulations or Wickham's striae. So the papular lichen planus is usually difficult to encounter in a clinical setup because usually patients do not come to the clinic, especially this is asymptomatic, and patient won't come unless and until they become symptomatic. So papular LP is a common but rarely seen in a clinical setup. Next is bullous LP. There will be bullae or vesicles filled with blisters. But it cannot be seen in a clinical setup because these bullae will rupture, leaving behind ulcerated or abraded epithelium. Coming to the diagnosis of oral lichen planus, it is solely dependent upon the clinical features and the histopathological diagnosis. The histopathology of oral lichen planus, there will be hyperparakeratosis or hyperorthokeratosis, thickening of granular cell layer, sawtooth retipex, liquefaction degeneration of basal layer, dense subepithelial band of lymphocytes, dead epithelial cells with shrunken eosinophilic cytoplasm and pycnotic nucleus, that is sewage bodies. Some sewage bodies not phagocytosed extrude into the dermis coated with this IgM antibodies, and they are known as colloid bodies. So histopathology is now considered very important for the diagnosis of oral lichen planus along with its clinical feature. Immunofluorescence studies are also done as a part of diagnosis of oral lichen planus. Immunoglobulin or complement deposits are not a consistent feature of oral lichen planus. In some instances, fibrinogen and fibrin are deposited in a linear pattern in the basement membrane zone. Coming to the differential diagnosis of oral lichen planus, there will be lichenoid reaction, leukoplakia, mucous membrane pemphigoid, candidiasis, and squamous cell carcinoma. Treatment. The first line of treatment is corticosteroids. Topical application, hydrocortisone, prednisone, prednisolone, betamethasone, beclomethasone, and fluocinolone. Systemic, triamcinolone acetonide or hydrocortisone, triamcinolone diacetyl or prednisolone with 50% lignocaine, weekly intralesional injection. The side effects very common with the use of steroids are there will be increased blood sugar, especially in those with diabetics. Then in adrenocortical suppression. The second is retinoids, topical and systemic. Tretinoin and isotretinoin. Systemic is etretinate and tamarotene. The side effects are liver dysfunction, cheilitis, and teratogenicity. Third one, dapsone, doxycycline, and antimalarials, both topical and systemic. Fourth, cyclosporin topical application, where they have a side effect of hydrophobicity and unpleasant taste. The important thing of oral lichen planus is its malignant potential, which we discussed along with the erosive lichen planus. Malignant transformation of oral lichen planus remains a very controversial issue. The first report outlining the development of an oral squamous cell carcinoma from an OLP lesion was published more than a century ago. 1978, WHO classified oral lichen planus as a pre-malignant condition or precancerous condition. Precancerous condition, as you know, that it is a generalized state of the body which is associated with a significant increased risk of cancer. Later, in 2005, these pre-malignant lesions and precancerous conditions all put together and form oral potentially malignant disorders by World Health Organization. The malignant transformation of oral lichen planus is 1.1% to 1.4%. At least some reported cases diagnosed originally as OLP on clinical and/or histological grounds were probably epithelial dysplasia or lichenoid dysplasia that progressed subsequently to overt squamous cell carcinoma. Many studies have exaggerated the potentially malignant nature of oral lichen planus. Oral epithelial dysplasia or lichenoid dysplasia was considered a precluding factor of OLP diagnosis from 2003 onwards. The OLP lesions are consistently more persistent than the dermal lesions and have been reported to carry a risk of malignant transformation to squamous cell carcinoma of 1.2%. Approximately it is 0 to 12.5% reported by various studies. Now, while we are discussing oral lichen planus, always we have to discuss about lichenoid reaction also, which comes along its first differential diagnosis. Lichenoid reactions are oral mucosal lesions that resemble oral lichen planus both clinically and histopathologically. But lichenoid reactions are always associated with either an administration of a drug, usually the lesion resolved following the withdrawal of the drug, contact hypersensitivity to certain dental materials such as amalgam restorations. Then there are lichenoid reactions seen in chronic graft versus host disease. To conclude, Oral lichen planus is a very common oral dermatitis, and it is one of the most frequent mucosal pathosis encountered by dental practitioners. It is imperative that the lesion is identified precisely and proper treatment be administered at the earliest. A proper understanding of the pathogenesis, clinical presentation, and diagnosis of the disease becomes very important for providing the right treatment. Although the incidence of malignant transformation of oral lichen planus remains controversial, careful, regular, and long-term follow-up of patients with oral lichen planus is required for the early detection of malignant transformation from oral lichen planus. The follow-up interval ranges from 2 months to an year. Patients with the reticular form of oral lichen planus may be assessed annually, while oral lichen planus with dysplasia should be examined more frequently, example every 2 to 3 months. And if erosive changes are evident in lesions, at least follow-up visits, additional biopsies are mandatory, and the follow-up intervals should be shortened. So this is all about oral lichen planus. I hope you have an overview of the oral lichen planus. Hope you had a very good session. Thank you very much.